So we begin with what are fibroids. I'm sure all of you already know what are fibroids. I'm not starting from the real basics. So it's a tumors which arise from the uterus. They could arise at classification system, which the International Federation of Gynecology and Obstetrics we call as FIGO, which is one of the nodal bodies when it comes to gynae-obs. They gave this classification system to sort of be able to classify what is the location of the fibroid and how far it is located from the endometrial cavity, as intramural, where it was within the wall of the uterus, submucosal, if it was hanging into the cavity, subserous, if it was outside the uterine wall, panmural, if it was involving more than one wall, like it was involving anterior to posterior, for example, and parasitic. Parasitic means fibroid is not directly connected to the uterus, but is still was at one time part of the uterus and is getting blood supply from some of the vasculature, which is also supplying the uterus or any other, say from the omentum. So those were called, so that was the classification when we were growing up. We used to just say fibroids are intramural, subserous, submucous, and panmural. But FIGO gave this classification system, and the reason behind classification systems is that it makes things more objective. So that's why the submucosal fibroids, they were 0, 1, and 2 came as submucosal. So if you just follow the diagram, 0 is one which is completely inside the cavity and it's got a pedicle attached to it, or a kind of thing, a stalk by which it's hanging from the wall. So that is called a type 0. We call them, we say that in types. So this is called a type 0 fibroid. Then there is a fibroid which is partly in the wall, but also partly hanging into the cavity. So if more of it is hanging in the cavity, that's called a type 1. If less of it is hanging into the cavity, more into the wall, that's called a type 2. So all three are types of submucosal fibroids, but the treatment for them differs slightly. Then the intramural ones also, 3 is the one which is completely within the wall, but it is still touching the endometrial lining. 4 is one which is properly intramural, it's not touching either the serosal lining or the endometrial lining. 5 and 6 again, so if we are going from inside out, so 5 becomes an intramural one, but which is becoming subserous. So it's called subserous with more than 50% of the intramural component. Type 6 has less intramural and more subserous component, so more of it is hanging outside the uterus. And then the proper subserous one is the one which has a stalk and it's just hanging by the side of the uterus, not actually touching the uterine wall, but at the stalk location. And then we have some fibroids which are not within the wall, but they are either in the cervix or the broad ligament or the parasitic ones we used to talk about. So those are called non-myometrial fibroids. And sometimes we have a fibroid which is really big. So it is in the cavity, it is touching the cavity, it is touching the serosa, and it's within the wall. So then we give it a annotation where the numbers are 2. So for example, 2-5 would mean that it's starting from the submucosal, but going as far as the subserosa, engulfing the whole uterine wall. So this is how we classify fibroids. And the reason we do this is the way we would tackle such fibroids depends on this. So exercise it safely, uterine fibroid, which is completely 7, usually doesn't require surgery, because these are not the fibroids, unless they are very large. These are not the kind of fibroids which generally cause any. And then one which is 3 and 4, they generally need an into the wall of uterus to excise it. So 3, 4, 5, and 6 would need surgery from the abdomen, while 0, 1, and 2 could be tackled from the vaginal route using a hysteroscope. So that is how also it is relevant, the classification. Now, these are few images of fibroids. Sometimes there's a big fibroid, there are multiple like this, and there's no real clear distinction. Is it subserous? Is it intramural? The image which is so fibroids, because when they grow very large, blood supply gets cut off, they outgrow their supply, and part of it starts. You may have read about it in your undergraduation. This again is a very huge mass of conglomerate mass of multiple fibroids. You can't even tell each of the fibroids apart. Sometimes there is a big one and there are multiple small seedling ones. This one is also showing degeneration within the fibroid. This kind of degeneration we call as hyaline degeneration. So fibroids can have various kinds of degenerations. Otherwise, you can see a proper world pattern of appearance. I will show you in maybe one of the videos. You'll be able to clearly see what we call as a world pattern of appearance, which is very typical of fibroids. Now, what is so that is about fibroids. Then is the surgery for it, and how do we tackle fibroids? So fibroids, if they have no symptoms, then one can just wait and watch. Most of the times they are detected incidentally, for maybe ultrasound having been done for some reason, or MRI having been done for the spine, for example, and an incidental diagnosis of a uterine fibroid is made, and the patient really doesn't have any symptoms. So in those scenarios, there is no need to just rush in with the knife and do something just because a fibroid is detected. We generally wait and watch and see if it is actually going to cause any trouble to the patient. Then there are fibroids which become symptomatic. Now, symptoms in fibroids are generally related to the periods, so that it pads very frequently, or they can also lead to painful periods. So because the uterus kind of hypertrophies, so more surface area is there for the lining to shed, hence the heavy bleeding or menorrhagia as we call it. And because some of them, when the uterus contracts during the period, it constricts on the fibroids also, and it leads to painful periods. And sometimes a fibroid which is hanging within the cavity, for example, the submucosal one, may even try to get itself expelled from the uterus with the period, and that also leads to spasmodic pain. In addition, you do understand that if the uterus is distorted by the presence of fibroids, it wouldn't be easy for a patient to conceive. So the other symptom which is seen with fibroids, which we take as a symptom, is inability to conceive. Now, this is generally seen when the fibroids are within the cavity, because they are directly interfering with the implantation of the embryo. The ones which are subcutaneous don't interfere with fertility, and they also don't cause as many symptoms of heavy bleeding or pain or anything. But yes, the ones which are in the wall can also interfere with conception. Then we come to how do we manage the symptomatic fibroids? Now, the management of symptomatic fibroids, there are only two criteria. One, does the patient want to have children, or does she want to have children at all? These are the two criteria which determine what treatment the fibroids follow. So for a person who wants to have pregnancy, there is only one treatment option, and that is myomectomy. There is no other treatment option for a patient who wants fertility and has fibroids, and the fibroids are causing her infertility. Then myomectomy has to be done. That is the only treatment option. So very simple here. Symptomatic fibroid wants pregnancy, needs myomectomy. Where fertility is not desired, it depends on patients, or she does not preserve. So a person who has, for example, does not wish to, maybe is in her late 40s, can undergo, we need to give some surgical medical treatment to shrink. Have to give a big fibroid approach. But once it is shrunk by medical treatment, it is sometimes possible to go ahead. But there are those who don't want fertility but still preserve the uterus.